Thank you again, Dr. Kachura, for joining us. Could you please briefly tell us how you came to be Professor John Kachura?
Well, I went to University of Toronto Medical School. I graduated in 1989, a long time ago. And then I was originally in the internal medicine program. But my last elective in medical school during the clinical clerkship was radiology at the Wellesley Hospital, now defunct. But I really enjoyed the breadth of material and the intricacies of radiology, and I decided to switch. So after a year of straight or comprehensive medical internship, I switched to radiology at U of T, did my radiology residency there, finishing in 1994, and then did a fellowship in Boston at Boston City Hospital, University Medical Center. It's now called Boston Medical Center, for a year, and then came back to Toronto working on staff at the Wellesley Hospital for 3 years before moving to UHN Mount Sinai on staff, where I've been since 1998.
Excellent. First one. So who is or was your mentor and why?
So during radiology residency, I enjoyed most of the things we learned back then, but I wasn't sure what area of radiology I would want to subspecialize in. I didn't know what kind of fellowship I wanted to do, if I wanted to do a fellowship. And my first block or rotation of interventional radiology was at Mount Sinai Hospital during my R3 year, which would be PGY4. That's the first time I was actually on a rotation for interventional radiology, and my staff people on the service were Murray Ash and Nasir Jaffer. And in fact, Murray Ash was my first mentor. As soon as I started doing that rotation, interventional radiology with Murray Ash, I knew that's what I wanted to do. And then it was kind of late in the year for fellowship applications, so I was kind of scrambling for fellowships. But I was lucky enough to get some positions in Boston offered to me, so that's what started things off. So he was my first mentor, and then in Boston I had a couple of mentors that I really looked up to. My program director, Joseph T. Ferrucci II, and Kent Ussel, my program director. And back in Toronto, I would count CSO and the recently departed Kent Snyderman as mentors as well.
Now, back in the olden days when you applied for your fellowship, was interventional radiology, like, was it even well known throughout the hospital? Like, did other referring physicians know about it? Like, what kinds of cases were you doing back then?
Yes, it wasn't the prehistoric times. So there was interventional radiology, and the main people at UHN and Toronto General Hospital, the UHN and Mount Sinai were not amalgamated yet.
Okay.
And in fact, Toronto General was separate from Toronto Western Hospital. So all these hospitals are separate entities. At Toronto General, the main people doing intervention at that time were Kent Snyderman and CSO.
So what part of IR were you drawn to?
I liked using my hands to do procedures, and was fairly good at the basic procedures during my internship, for example. And it seemed satisfying to do something to help someone in the immediate term. Internal medicine I was interested in because of the complexities, but it seemed that you had to deal with a lot of chronic conditions for which there were no easy answers.
Well, now, would you consider yourself more of a vascular interventional radiologist or a body interventional radiologist?
I think I like both. I wouldn't want to choose one over the other, so I would say both.
Cool.
I mean, over the years, as an interventional radiologist, your specific interests can change, and a lot of that is related to what's available to you, your environment, for example. So when I first started, stent grafting, endovascular aneurysm repair was fairly new, so I got into that, and I was one of the people that did some of that with the vascular surgeons at Toronto General Hospital. In fact, we did one at the Wellesley Hospital. But as times changed, and radiofrequency ablation became the new thing in the late 1990s, I got into that, and I did a lot of interventional oncology since then. So I think I tend to be more involved in interventional oncology now than other things like peripheral vascular disease, but I like to do all those procedures.
Cool. So now, this is a very difficult question, I know. How would you describe your favorite catheter?
Well, I frequently teach the fellows that the 4 French C2 glide catheter is the most versatile catheter known to people kind. I used to call it known to mankind, but times have changed, of course.
Good. Okay, so you've adapted to that. It's nice to
Yep.
see. Yeah. Do you still use the 4 French C2?
Yes, I use that for my uterine fibroid embolizations, for example.
Okay. Excellent.
There's disadvantages to using it, so I appreciate how some find it difficult to use. It is quite flimsy, it kinks and twists very easily, but that's part of its advantage as well. It's not as it doesn't cause damage to the vessels, I find, and I can use it in many different ways.
Do you have a favorite CAIR city, or like a CIRA meeting city or CAIR meeting city?
You know, the first year it was ever held was in Niagara-on-the-Lake, and that was that produced a lot of memories, which I still remember. Oddly enough, it was a great time. And then we went back to Niagara-on-the-Lake a couple years later, so the times there were great. I enjoyed Halifax and I enjoyed Calgary. As long as it's not in Toronto, I'll enjoy it.
What's your favorite song to sing at karaoke?
Well, that's an interesting question. It really depends on a lot of factors. So I have to scope out my audience, my competitors, and the venue. So it really depends on a lot of factors. So I have a selection of go-to songs, and it really depends on those factors.
Okay, so I mean, kind of set the stage, like describe something to us, like maybe not a competition. What if it was just a bunch of other interventional radiologists
In Saskatoon
for a meeting, drinks are being consumed, everyone's having a fun time, it's not a contest?
Well, there's where you're wrong, because karaoke is always a contest. It's a contest of who could get the microphone out of my hands. So I will not divulge my secrets.
Oh, you're not even going to tell us your song. Okay. Okay.
I have a number of them.
Okay. What was your last publication, Professor?
Can I look that up? I think it was a letter to the editor. I was a co-author. It was a letter to the editor to, I think, CBIR, and I'm very proud of it. Although I did not write the draft, I was very pleased that in that letter to the editor, the word Trump was in there and fake news.
Really? In the letter to the editor?
You'll have to look it up.
Okay. Yeah. Do you know what we might do is try to
Kennedy, Kachura, and Maffeld.
What is your favorite closure device if you were to use a closure device?
I think my favorite closure devices are this and this.
Right. Fair.
Hopefully on the fellow's hand.
Right. And what if there was operator fatigue?
Then you'd have another hand.
Okay.
There's another fellow.
endless fellows. Okay.
Dr. Kachura, do you have a favorite technique that you enjoy either teaching fellows or watching fellows attempt to perform?
Well, something that comes to mind is the way to remove a loop from in the stomach. Let's say we access the stomach percutaneously through the anterior abdominal wall, and we are trying to get into the jejunum, and we've crossed the pylorus. We have good access with a catheter and or wire to the proximal jejunum, and but we have a loop running along the curvature of the stomach, and it's nice to show fellows this trick where you put a flimsy catheter in, or just a long 5 French multi-purpose catheter without the wire in place, and then I tell them to do the jerk and twist maneuver, where they violently rip a portion of the tube out of the body while twisting at the same time to get rid of that gastric loop. Mm-hmm. And sometimes they're amazed like small children. It's nice to see.
That is. I think he taught me that one too. So Yeah, along the same topic, how long do you wait and to feed someone after a new G-tube insertion? So fresh G-tube insertion, what's your NPO afterwards?
I think you can use it right away, but I think you have to decide in your institution what the rule should be, just so people don't get confused and you don't run into trouble. In the old days, we used to say 4 hours. In another place, we said 24 hours. It really depends on how the procedure goes as well, and what kind of tube you're putting in.
Okay.
With our current balloon gastroscopies that we place, which are 14 French, but we need an 18 French peel away sheet to put them through, I would agree with some period of time of being NPO.
And
But
do you,
I don't have a strong feeling about it.
okay. And are you using T fasteners, or are you just going in with the balloon retention?
I rarely use T fasteners, but others use them more routinely. I tend not to use them unless there's ascites that you can't get rid of or you're concerned about, or some other problem.
Okay. Yeah.
Do you yourself have a favorite procedure?
Yeah.
I don't. I can't think of something that I would rather do every day, but I like a variety of things. So I don't have a specific favorite procedure.
Do you still enjoy when fellows put too many coils in and so you have to go and snare them out?
Yes, that happens from time to time. And I just showed a case this morning at our rounds of that happening during a varicocele embolization.
Ah, yes.
It's, sometimes it's good to experience that as a trainee, so you're a bit more familiar with it when it happens to you when you're on your own.
Yeah.
So sometimes I coax them to tell them, oh, put another coil in. Yeah, there's room, when I know there isn't. Because that's another rule that I have is if it looks like there's room for one more coil, there isn't.
Yeah, I remember that one too. And I use that one as well.
I like to act like a mother lion with her cub, catch the prey, injure it a bit, let the cub play with it a bit until the prey starts to run away, and then I grab it.
Have you ever gone skydiving?
No, I have not. I'm very afraid of heights, actually.
Are you? But do you enjoy skiing, it sounds like?
Yeah, the kids are very good skiers, and I get down the hill in one piece most of the time.
Okay. What advice do you have for a new IR staff?
Well, something I tell I was going to say all fellows, but I don't know if I remember telling you guys, is during our exit interviews, I give them a piece of advice that after the year with us, you have the basic skills and approaches to attack any problem given to you, any problem heading your way. But it's okay to feel concern or caution and uncertainty. A little bit of lack of self-confidence is okay. That means it's much better to feel that way than to be overconfident in terms of patient safety. And it takes a good 2 to 3 years of practice on your own before you feel a lot more comfortable in approaching new problems. And that's okay.
But what do you think is kind of the biggest kind of issue that might face interventional radiology kind of in the future?
I feel pretty optimistic about the subspecialty. I think we always have to be cognizant and vigilant about doing the work, not only the physical work, but the patient care part you can't slack off on that. Research, I think, is important for at least some of us to be involved in, and always having people involved in committees and administrative work, although it's very time consuming, and some people who love meetings shouldn't be involved in any managerial position whatsoever, but it's a necessary thing in terms of us to be at the table to discuss issues that affect us in the future and other patients. So I think that's important as well. So administrative work, maintaining the research in some capacity, and maintaining patient care are important things for a specialty moving forward.
When you started, did you have access? Because I remember from fellowship, you have nurses that I feel like maybe a few of the IRs will share, like a clinical coordinator or a nurse, and you have dedicated clinic time and clinic space and an actual office. Was that in place when you started, or was that something you had to kind of fight for, or like, and what was that process like? Because that's something that we're definitely struggling with. And I think a lot of people across the country, IRs, are struggling with, trying to truly establish like a clinical practice and the supports needed for that. Like, we're all doing it off the side of our desk, more or less.
That's a great question. And to really answer that properly would take a long time, but let me try to encapsulate it in a few minutes. You know, when I started in 1998 at UHN Mount Sinai, we didn't have any of that infrastructure that you mentioned. I recall we were just starting uterine fibroid embolization in 1997 or so, and I would receive a fax from the front desk, an actual piece of paper that looked like it was a referral to a doctor to assess a patient for uterine fibroid embolization, which was an odd thing for interventional radiologists at that time. So I remember that I would wait till the day was over, phone the patient, tell them to come in on a certain day at 5 p.m. I meet the patient at the front desk, bring them into an office, do the consult, dictate a consultation note into a little handheld dictaphone, find a secretary to transcribe it like a real doctor, and send it off, and then go to bookings myself and fill out all the pre-admission forms, take them to the pre-admission unit myself, book all these things myself, and that was very time consuming and taxing. And but that's something you have to do to start things off. And then eventually you give enough work to the secretarial staff in terms of booking these things, and they complain to their manager saying, we have too much work from these interventional radiologists booking all these things and this administrative stuff, and then they will miraculously give you a secretary just for the interventional radiologist, and that eventually builds on other things like getting a clinical nurse coordinator, which we got many years later to handle organizing more complex things like what patients need for chemoembolization, for example. And now we have 3 clinical nurse coordinators to help with all that. And then we found that, you know, I can't keep doing this after hours all the time. So I have to be in charge of the schedule as division head for a short period of time. And, you know, when no one was looking, we booked some of us in for a half day of consult time where we weren't doing procedures, and that stuck. And now every interventional radiologist has at least half a day a week of consult or clinic time, and they can't take that away from me. So that sort of thing happens gradually and slowly. You have to put in the work first, but then you get rewarded because the infrastructure will come together gradually.
Did you get much pushback from your diagnostic colleagues with that?
Absolutely. So there's some of that. So sometimes that is a battle you have to pick, but in general, the diagnostic colleagues are usually on the same side as well. And you just paint them the picture, and they understand, they realize that in the end, that's best for patient care.
Do you do any diagnostic work, dictate CT or MRI or anything?
Yeah, not as much as some of my colleagues, but yes, I can do that, and I have done that.
Okay.
CTAs.
CTAs. Okay, mostly CTAs, because I think we did CTAs in fellowship, but very periodically. Yeah. Okay. Cool.
There's more
now. Yeah. I don't know. I think that was the question I kept looking for and I kept forgetting about.
We've covered a lot.
Yeah, we did. We went
through good.
We'll make sure it's not too long though.
No. We'll edit it down and we'll take some stuff out. And we don't, again, we're kind of looking at this as a bit of an experiment. Like, nobody really cares.
Yeah, you have to make it short. After a few minutes, people will stop listening.
Yeah, exactly. Like 10 to 15 minutes. And then I think anyway, we'll do a write-up part. Obviously
in English and French.
English and French. Write-up part, and then some sort of a visual one. And who knows, maybe this will be the first and only time we ever do it, but everyone's spent the last year in Zoom meetings. So it's, well, it's interesting. And you've trained, I feel like you've trained the vast majority of people who are involved in CAIR. So I think that I'll be interested in
or not interested.
Or not interested. Because haven't you trained like Tara, Amal,
Melissa, Beecroft.
yeah, and Jason Wong too?
No, he's a contemporary colleague.
Okay.
Might be a few years younger.
Okay.
Corey?
Who?
Corey?
Yeah, Corey Coughlin. You
Corey
trained.
was my fellow, yeah.
Yeah, I remember that. Okay, good. I'm actually going to turn off the recording now.
Between two probes.